Good evening, and welcome to our program, Challenging Cases in Allergy, Immunology, and Respiratory Disease, Personalized Approaches to Acute Hereditary Angioedema Management. This activity is provided by Integrity CE, and this activity is supported by an educational grant from Pharming Healthcare, Incorporated. I am Dr. Maeve O'Connor. I'm Clinical Assistant Professor at the University of North Carolina in Charlotte. I'm also a practicing private practice allergist and immunologist. I'm the Medical Director of Integrative Allergy and Immunology Care, and I'm also the Chief Medical Officer of the Consortium of Independent Immunology Clinics, and my disclosures are listed on the slide for you. And I'd like for Dr. West, my colleague, to introduce himself. Dr. West?
Hello, hi. Thanks, Dr. O'Connor. My name is Brett West, and I'm a physician and allergy and asthma specialist in Dallas. I'm also a sub-investigator at the AARE Research Center with a special interest in hereditary angioedema. And I appreciate you guys having me today. My conflicts are listed here on the slide as well. Thank you.
Thank you very much. So these are our learning objectives for the program this evening. We're going to be analyzing the benefits and risk of currently available and developmental therapies for the treatment of acute hereditary angioedema attacks. We're also going to discuss how to implement shared decision-making for the individualized selection of treatment for patients at risk for acute HAE attacks. We'll be exploring the evolving landscape in the management of HAE with a particular focus on patient-centered strategies and real-world clinical applications. Hereditary angioedema, the burden of acute attacks despite prophylaxis. Hereditary angioedema is a rare and potentially life-threatening disorder characterized by unpredictable episodes of swelling. And these swelling episodes can occur anywhere in the body. They can affect the skin, the GI tract, the upper airway, but again, they can occur anywhere, even in a hand or foot. Timely recognition and appropriate management are essential to improving patient outcomes. There is a large disease burden of hereditary angioedema, and the burden of HAE extends well beyond acute attacks. Patients live with constant fear of the unpredictability of their swelling episodes, and these swelling episodes can severely impact many parts of their lives, including work, school, and even just normal daily activities. There's emotional distress, anxiety, and isolation that can be seen commonly in these patients, especially in those patients with HAE that have frequent attacks or those who have attacks that involve the larynx. So when we think about this, it's an attack and then quality of life disruption, attack, quality of life disruption, kind of in a vicious cycle. And the burden of the attacks can be from many different things, including the location of the attack, the severity of the symptoms, the duration of the symptoms, and whether or not they have to seek emergency care or even if they have to get hospitalized. But the disruption of life caused by the attack cannot be minimized. And then in between, again, that quality of life disruption, that fear of the next attack, anxiety, and even depression are increased in patients with HAE. It can interfere not only with daily work or daily school, but it can interfere with the advancement of education and career. And oftentimes, most of these patients have to employ lifestyle modifications to avoid triggers that they may be able to identify as a cause for their acute HAE attacks. So what about the clinical features of HAE? So HAE often presents with those recurrent episodes of swelling that I mentioned. And these swelling episodes are non-pruritic and non-pitting. And it's very important to note that there's no urticaria and there's no itching. And this is very important to differentiate hereditary angioedema from allergic angioedema. And attacks, again, can involve any part of the body, including the extremities, face, abdomen, or airway. But again, unlike histamine-mediated angioedema, there's no itching, there's no hives, and HAE does not respond to antihistamines, and HAE does not respond to steroids. Now, HAE is typically an autosomal dominant disorder, and there are two main types and then a third type. So there's HAE type 1 and HAE type 2, which is characterized by a C1 inhibitor deficiency or a C1 inhibitor dysfunction. And then there's HAE with normal C1 inhibitor, which is also known as HAE normal C1 inhibitor. And these patients will have the symptoms of HAE, but they will have normal levels and function of C1 inhibitor. But again, the presentation can be identical to HAE types 1 or 2. And then the acute attacks can have variable onset. So these can occur variably, but the majority of them do develop gradually over hours. And it can be several hours, including a whole day. These can be prolonged with increasing intensity over 24 hours. And these acute attacks can resolve in 2 to 4 days. Again, standard treatment for allergic reactions like antihistamines, corticosteroids, and epinephrine are ineffective, which can be a key diagnostic clue. A patient comes in and says, I have these swelling attacks. They always give me antihistamines or steroids, and it just doesn't work. Even epinephrine doesn't work. And again, the unpredictability of attacks is another key diagnostic measure. And again, that unpredictability can be in both frequency and triggers. And this is what makes it difficult to appropriately diagnose these patients many times. There's often a long delay to diagnosis from the onset of symptoms. Again, commonly affected areas: face, extremities, the genitals, oropharynx, and the GI tract. And oropharyngeal swelling can lead to airway obstruction, which makes hereditary angioedema potentially life-threatening. Again, very important to diagnose it accurately and as quickly as possible. And when we think about the acute exacerbations that can occur in the GI tract, swelling of the bowel wall can cause severe abdominal pain, and it can mimic a surgical abdomen. It can also be accompanied by nausea and vomiting. Oftentimes, patients that have GI symptoms will get numerous radiographic studies, and many patients often will undergo exploratory laparotomy and other unnecessary surgeries because, again, the GI tract swelling can mimic a surgical abdomen. So symptom onset can occur in childhood or adolescence, but again, as I mentioned, the diagnosis can frequently be delayed due to low awareness of the disease because it is a rare disease, which is why we do educational programs like we're doing tonight. So common triggers can include physical trauma, even minor trauma like repetitive work, surgeries, or dental work. Emotional stress can also participate attacks in some patients. So having an exam coming up or an important deadline at work. Estrogens, such as oral contraceptives and pregnancy, can also trigger acute exacerbations. And again, it's very important to recognize and minimize known triggers as much as possible, which can be challenging because, again, these swelling episodes are also defined by their unpredictability. So sometimes the trigger can be identified and sometimes it cannot. So this is a slide that shows the HAE classification into those 3 main types that I described earlier. So again, type 1 hereditary angioedema, that is hallmarked by low C1 inhibitor levels. Type 2, these patients will have normal C1 inhibitor levels, but their C1 inhibitor will be dysfunctional, and we can see this on the assay. And then HAE with normal C1 inhibitor is often associated with mutations in the genes that are listed here. So of course, SERPINE1 is the gene that we're most familiar with HAE type 1, but here you can see the genetic mutations that are associated with normal HAE with normal C1 inhibitor. So we can have factor 12 mutations, plasminogen mutations, angiopoietin-1, kininogen-1 mutations, MyoF mutations, and many others. And these mutations have been identified actually in pretty recent years. And we know that there are more genetic mutations out there that are still being identified. But the classification helps us guide our diagnostic workup and informs appropriate treatment selection for our patients with hereditary angioedema. So I mentioned trigger avoidance and the identification and avoidance of known triggers that can help reduce attack frequency and improve quality of life. And this can include many things that are here depicted on the slide. So whether this is managing stress, positive or negative emotions, whether it's managing infections such as the common cold, flu, or even other viral infections, The trauma that I mentioned, whether that's repetitive motion that can be seen in many different occupations, including carpentry and things like that, and also certain medical procedures, including dental procedures, fatigue, making sure that patients with HAE are getting enough rest, the avoidance of the hormones, as I mentioned. And this is not always possible, especially with pregnancy and menstrual cycles, but it is a consideration when we think about oral contraceptives and other forms of hormonal contraception that should be avoided in these patients. So all of these different triggers, the patients need to be educated on all of them and the best way to avoid them, because trigger avoidance is an important complement to the pharmacologic strategies that we have for avoidance of issues in patients with hereditary angioedema. So when we think about those acute attacks, such as I've described, we now have many different treatments for the on-demand treatment of hereditary angioedema. And from a historical perspective, you can see here, this timeline shows the evolution of FDA-approved treatments for HAE. So starting with intravenous plasma-derived C1 inhibitor in 2008, the treatment landscape has progressed remarkably to include subcutaneous, recombinant, monoclonal antibody, as well as oral therapies for on-demand treatment of HAE exacerbations. And the development of novel therapies has expanded patient choice and allowed us as healthcare providers to tailor our treatment plans and make them as least burdensome as possible for our patients. And I've been treating patients since just before 2008. So I have been on this journey with patients as the treatment landscape has evolved. And it has been an exciting and very successful journey for patients. And having this expanded choice has again allowed that tailored care for these patients with the rare disease of hereditary angioedema. So you can see here the on-demand therapies for HAE looking at the mechanism of action. So we know that acute hereditary angioedema attacks require prompt on-demand treatment. We know that this reduces morbidity as well as the risk of mortality from asphyxiation, which can occur from those oropharyngeal attacks. So when we look here at the available on-demand treatments, we see that they target different points in the bradykinin pathway. Icatibant blocks the bradykinin B2 receptor, so this prevents bradykinin from causing vascular leakage. Ecallantine inhibits plasma kallikrein, reducing bradykinin production. And C1 inhibitor replacement, whether that's human or recombinant C1 inhibitor, restores the deficient or dysfunctional C1 inhibitor, addressing the root cause of excessive kallikrein activation. So now we're going to look a little bit more closely at the evidence in support of each one of these therapies. So C1 inhibitor replacement for on-demand treatment of HAE. So this was one of the first studies to evaluate the on-demand treatment of HAE. And this was published by Craig and colleagues in the Journal of Allergy and Clinical Immunology in 2009. And you can see that the results here demonstrated that symptom relief from acute HAE was achieved significantly faster with C1 inhibitor versus placebo. And I think it's important to point out the favorable safety profile. There were no seroconversions or transmission of bloodborne viruses in this study. And honestly, even though this was published in 2009, it's really important to note that C1 inhibitor remains a trusted and widely used option for on-demand treatment of acute HAE exacerbations. Edema 3 was a trial that was published in 2010 in the New England Journal of Medicine, and findings from the Edema 3 trial showed that ecallantide effectively reduced symptom severity compared to placebo. And the key endpoints here were the treatment outcome scores as well as the mean symptom complex severity. And you can see that both of these ecallantide effectively reduced those compared to placebo. Again, it's important to point out that there were no deaths or treatment-related serious adverse events that occurred in Edema 3, so that supported its safety for use in the clinical arena. FAST-3 was published in 2011 in the Annals of Allergy and Asthma and Immunology by Dr. Lumry and colleagues. And this was looking at icatibant for the on-demand treatment of hereditary angioedema. And you can see here that icatibant provided faster symptom relief than placebo in non-laryngeal hereditary angioedema attacks. Now, injection site reactions were common, but they were mild and self-limiting. Icatibant offers a self-administered subcutaneous option, which is beneficial for some patients who want that type of independence and who do not have needle phobia. So more recently, FDA approved was sebetralstat for the on-demand treatment of hereditary angioedema. And this was published in the New England Journal of Medicine in 2024 by Mark Rydell and colleagues. This is the CONFIDENT trial, which evaluated sebetralstat, which is an oral plasma kallikrein inhibitor for acute attacks. And this study demonstrated faster onset of symptom relief, significant reduction in attack severity, rapid complete resolution of attacks, as well as a favorable safety profile. Sebetralstat and placebo had similar safety profiles, and there were no SAEs related to the trial agent reported in CONFIDENT. Again, this was recently approved, and this was published in 2024. Now, there are some emerging on-demand treatments, and I would just like to point out deucrictibant. This is one of the new therapies that's currently under investigation for on-demand treatment of HAE. And this is an oral bradykinin B2 receptor antagonist. Phase 3 trials include RAPID E3, Chapter 3, and Chapter 4. And this is being looked at not only for on-demand treatment of HAE, but also for the long-term prophylaxis of HAE in patients 12 years of age and older with type 1 or type 2 hereditary angioedema. And these trials are currently recruiting, but so far the data is promising. Chapter 1, as you can see here, this is phase 2 trial of deucrictibant. This is a small molecule kallikrein inhibitor, and you can see the overall monthly attack rate, moderate and severe attack reduction, as well as the on-demand treated attacks here. And all TEAEs have been mild in severity, no serious TEAEs, severe TEAEs, or TEAEs leading to treatment discontinuation, study withdrawal, or death have been reported. And as I mentioned, early results are promising. Development is ongoing for deucrictibant. So what about some other evidence-based recommendations for the management of acute hereditary angioedema? So we know that it's important for patients to have immediate access to approved on-demand therapy. And it's very important to note that it's preferred from our hereditary angioedema guidelines that self or caregiver administration is preferred to make it easier for patients to have access to their treatment, and that all hereditary angioedema acute attacks should be treated regardless of location and severity. And again, these are updated guidelines for the treatment of hereditary angioedema. Back in the beginning of the treatment landscape that I showed you, there were some medication shortages and things like that. So these guidelines now are the most updated. So patients should have immediate access to approved on-demand therapy with self or caregiver administration preferred, and treating all attacks regardless of location and or severity of those attacks. And when we have our discussions with our patients and their caregivers with hereditary angioedema, we really want to personalize their on-demand treatment with our shared decision-making discussions. So we want to think about what administration route may be most appropriate for the patient in front of us that we're treating, looking at their history, looking at whether at-home administration, again, preferred, but is it appropriate for this patient, and their current treatment and whether it's working for them or not, duration of response, how quickly they respond, how long their attacks are lasting. All of these things need to be taken into consideration when we're personalizing the on-demand treatment for our patients with HAE. And the shared decision-making 3D model is shown here in HAE management. And it's really discuss, discover, decide, discuss, decide. It doesn't really matter the order, but the 3D model is really very helpful. So discovering the patient's needs individually, what the patient in front of you, what are their specific needs, their specific triggers, the impact of their HAE on their daily life, and what are the patient's goals for treatment? Because one patient's goals may be quite different from another patient's goals, and making sure that the options that we discuss with them are available to them, depending, of course, on their particular insurance. Then discussing with the patient, reviewing all of the appropriate treatment options, comparing the benefits and the risks, as well as some of the clinical data, and ensuring that the choices align with the patient priorities from that discovery discussion that occurred. And then the decision will be made, making informed joint decisions with the patient and the patient's caregiver, ensuring that they have clear instructions and confidence in the plan. So using this 3D model of shared decision-making, we know improves patients' confidence, not only in us as HAE experts, but also in the treatments that are decided on, and also in their adherence in using the treatment going forward. And this model really supports patient engagement, treatment adherence, and patient satisfaction as well. And I would argue as well as the HAE expert satisfaction. So the HAE patient action plan, there are some really essential components. The most important thing I can stress here is that the HAE action plan needs to be clear and written, whether that's written on paper or whether an electronic device has it listed there, whether it's in the notes or on an HAE app that may be used. It's very important that that plan be written, not only for the patient, but also for their caregiver, but also for those patients who may visit an urgent care emergency room that may not be as familiar with hereditary angioedema, so that they will understand what the plan is and how it needs to be followed. And again, key elements include that recognition of early attack symptoms, step-by-step instructions for self-administration of on-demand medication, because even though self-administration is preferred, if a patient is not able to self-administer, then the caregiver and or a healthcare provider may need to do it. Guidance on when to escalate care, when to seek emergency care, and then prophylaxis instructions and what to do for a missed dose, and then emergency contacts, including a backup healthcare caregiver, as well as the specialists that are involved, so that everyone can be on the same page. And reviewing and updating this plan regularly when patients come in for follow-up to make sure that it's updated on the most updated treatment plan that is being followed by that patient. But we know that a well-structured action plan improves patient confidence, timely treatment, and again, improves those overall patient outcomes for HAE in general, as well as for the treatment of acute HAE exacerbations. So now I'm going to turn it over to my colleague, Dr. West, to review a real-world case patient and apply some of the things that we just reviewed.
Great.
Dr. West?
Hi, thank you, Dr. O'Connor. Fantastic presentation. Thank you for that background in HAE and kind of presenting a nice comprehensive review of the on-demand treatments available. A lot has happened just in the past several years. So today we have a real-world presentation of a girl who actually presented to our office last year. She was 12 years old and she was having recurrent angioedema. In her current condition, she was having recurrent non-pitting, non-pruritic swelling episodes. She was referred, like I said, by her pediatrician for these issues. And her history kind of followed as such, where she was having, occasional swelling episodes around age 4, maybe 2 to 3 times per year, often around her eyes. By age 11, after menarche, her frequency increased to every few months. And she was, things were picking up for her. And then she ended up what really triggered kind of the referral, I think, was she had a severe episode of face and tongue swelling at age 12. At that point, she had presented to the emergency room again, treated with steroids, epinephrine, and kind of no matter what, her symptoms still took several days to abate. And so she would stay in the emergency room for a long time. And then finally, once they kind of clarified that her airway was protected, she would be discharged home to follow up with her pediatrician. Further kind of on her history, she had not yet experienced any abdominal attacks or laryngeal attacks, which was kind of on the last slide. But anyhow, so moving along with her history, her other past medical history is remarkable for kind of mild intermittent asthma. She was otherwise, rather healthy. Her vaccines were up to date. Her growth and development were normal. She had no medication allergies. Her current medications on presentation were Zyrtec daily. Um, importantly, she did not ever really increase the dose very much to 2 times per day. Albuterol is needed and epinephrine, of course, is needed. And we already kind of reviewed her brief hospitalization history where she'd never been admitted, but this last episode at age 12, really caught everybody's attention. Then importantly, her surgical history was remarkable for ear tubes at age 2, and then a tonsillectomy at 3. And then importantly, she had not really had any swelling events with those procedures. So here comes our first polling question. And I'm just going to read it, and then we will launch kind of the audience poll, an opportunity to answer these questions. So which feature is most suggestive of HAE in this patient? Is it A, swelling episodes beginning in early childhood and increasing after puberty? Is it B, attacks lasting 2 to 3 days without urticaria or itching? Is it C, lack of response to antihistamine, steroids, or epinephrine? Or is it D, severe facial and tongue swelling requiring ED treatment? So at this point, I think we'll launch the question and give everybody a chance to answer, and then we'll review things. Okay. So what we have here is kind of a Knight's Miss bag, and honestly, there's really no, I think, in my opinion, no wrong answer here. I think all of these are can fit the hereditary angioedema picture. So we have kind of 17%, almost 70% on the lack of response to antihistamines and steroids or epinephrine. And then nobody really went for the severe facial or tongue swelling requiring an ED treatment. So just kind of thinking, I'm going to close this, kind of thinking through my thought process on this. Well, if you don't mind kind of going back to the questions here so I can kind of list them off. So kind of looking at answer choice A, swelling episodes beginning, thank you, in early childhood and increasing after puberty. So this would track with the natural course of HAE. And frankly, with this patient, she was kind of, honestly reading the book. But when I think about swelling and causes, when I'm reviewing, a patient history, I also got to think about the other type of swelling. So Dr. O'Connor nicely went down kind of the bradykinin pathway and how that leads to that non-pitting swelling edema that can last for days. Well, obviously in the allergy office, we think about histaminergic or mast cell mediated swelling. And that can also have hormonal influence factors. So we're not always, maybe out of the gate convinced without the labs and other features. So I can see how that one would still, maybe fit both pathways or both causes of swelling. If we look at answer B, attacks lasting 2 to 3 days without urticaria itching, of course, that would track with hereditary angioedema or bradykinin mediated type swelling. Less likely histaminergic or mast cell, perhaps, but I imagine we've all seen a case or two where the patient swears that the swelling was without hives and still lasted a day or two, in which case that can still end up actually being histaminergic, but I still think it fits for HAE as well. If we go to answer C, which I think might be the most compelling answer here, or perhaps the best of the options, lack of response of antihistamine, steroids, or even epinephrine. If it was histaminergic or mast cell, you would expect some kind of sway or response in the emergency room to one swelling versus obviously bradykinin mediated, it may not budge much and it just still needs time. And as far as answer D, severe facial or tongue swelling requiring ED treatment, I still also think that that's definitely possible. But again, the mast cell or histaminergic type swelling can also present that way. Dr. O'Connor, do you have any other kind of additions here? Or...
Yeah, I mean, I just think with the orbital swelling, I think it would be very easy to think that that's an allergic conjunctivitis, or from a pollen or something in the air. So I wouldn't have thought that would have been an easy time to definitively diagnose her with HAE, especially since it was recurrent or just around the eyes. It'd be easy to think that. I think that the pediatrician is savvy, and I'm glad to see that the pediatrician referred for HAE. So maybe doing these educational programs is hitting out like we want them to, because that's certainly an appropriate referral. And then, of course, I think I definitely repeated many times that lack of response to antihistamine, steroids, and epinephrine. That's certainly one of the hallmark things, and it's very important, especially if somebody is having facial and tongue swelling. If epinephrine's not working, that is definitely a cardinal sign. So I agree with you that C is the best answer, but I think any of them could fit, including D, especially with C in mind, right? And of course, her symptoms blossoming right around menarche, that makes sense when we think about the hormonal influence in this disease, right? So I would agree with everything you said, and I'd be interested to hear a little bit more about the patient. Do you have anything else?
Yeah, I think you're pointing out that kind of, especially the ocular swelling, can be sometimes confusing, because we know in our pediatric patients, if there's an area on their face that's going to swell, even related to allergy, it often is the eyes, or somehow the lips, and so the picture can be mixed in presentation. So thank you for pointing that out.
Yeah, absolutely. All right, so we'll hear a little more.
Yeah. So on further social history, our patient lives with her mother. She's in 7th grade. She's active in volleyball and soccer. So that's important to note. As far as family history, of course, there's no formal HAE diagnosis in her family, but her mom does add that she has an aunt, or in Texas we say aunt, with food-related swelling in quotes, and a paternal uncle who swells with stings. So, in this particular history, just kind of looking at the social, there's some factors here. She's playing, contact sports. And so that's something to really keep in mind for her quality of life and future decisions. And then as far as her family history, I would say that, there's definitely something notable here. It's not just, bone dry. I know that 25% of the time we can have de novo mutations. But if there's any sort of, especially if it's like a distant uncle or aunt somewhere that maybe they don't have a lot of contact with, they just heard they swell a lot, maybe there's something there. And especially if it's somebody, who might be older, they might not have had exposure to, a good pediatrician or an aware internist or family med doc who, back in the day knew a lot about HAE. So I think that this history is very notable.
Absolutely. I agree with that. And also they being active in volleyball and soccer. If she's a competitive sports player, then the stress of that could also be something to consider, right?
Absolutely. Yeah. Our sports are getting way too stressful.
Exactly. Absolutely.
All right, going on here with her physical exam. So she was well developed, well nourished. She was just kind of hanging out in the office. She did have some features of possible, allergic rhinitis or allergic conjunctivitis. Her conjunctiva was clear, but she had some Denny Morgan lines. There was some moderate allergic shiners. Her inferior nasal turbinates were a little bit swollen with some clear mucoid discharge. Otherwise, her throat and neck exam were reassuring. Her skin, importantly, had no swelling, hives, angioedema, and I would probably also add here she wasn't really dermatographic. And then on her extremities, there was no swelling involved either. As far as her review symptoms and vital signs, there was nothing really notable from her review systems other than what was already reported, and her vital signs were very reassuring.
And at this stage, your suspicion for HAE is pretty high, right?
She has our attention. Yes, very, very much so. Again, I've been, sometimes you'll get patients who kind of have this, CI or chronic idiopathic urticaria or angioedema syndrome where their swelling can last for a little bit. And so you really want to kind of confirm with the labs. But with her, I mean, she kind of read the book.
Yeah.
So our next question here for our audience, what type of testing would you order for this patient? A, C4, C1 inhibitor level and function. B, GNA and genetic testing, C, allergy skin testing, or D, a CT scan. Now, to clarify, the GNA and G is kind of you can kind of see down there, it is a focused gene panel for next generation sequencing in HAE. Audience, a few moments to answer. All right, good deal. So we have about 80% responding with answer A and 20% responding with answer B, and then nobody taking C or D. And I think, again, no bad answer here as far as like A or B. C or D could maybe down the road, but it doesn't really help us out a lot, I think, right now for figuring out the etiology of her angioedema as to whether or not this is hereditary angioedema. So as far as answer A, yeah, I mean, these is guideline recommended screening or testing with the complement studies. It really helps us nail down the diagnosis. These labs are all commercially available throughout our country. As far as genetic testing, there's sometimes a consideration for this, all right? And especially if maybe this was a girl and we clarified that she did have HA and we want to screen family members. Well, what if she had a sibling who is under one and the parents or mom really wanted to know? Actually, genetic testing is feasible because we can get a buccal swab, or in underage, that our complement studies are not as reliable. So I don't think that's a bad answer. I just think maybe for efficiency and cost considerations, probably answer A might be best in the situation.
Yeah, I agree. And I think the guidelines do, say that the genetic test is available, but that A would probably be the more appropriate cost effective. It's, it's already a very expensive disease. But in the case of H1 with normal C1, HAE with normal C1, it may be appropriate to do the genetic testing in order to get proper therapy, right? But that would be further down the road.
Agreed.
And I think that it's interesting, the CT, unfortunately, when a lot of our HAE patients go to the emergency room or urgent care, they end up getting a lot of unnecessary tests for fear, the physicians, healthcare providers have fear of missing something, and maybe HAE isn't in their mind. So if with laryngeal obstruction, it makes sense that somebody may order a CT just to make sure. But I think in this case, absolutely, it would not be the right answer. But you can't blame them in this era of defensive medicine that we practice. But hopefully, we can teach everyone that wouldn't be necessary in a patient like yours, right?
Completely agree. Yes. Thank you.
Anything else that you think about this? Would you just do a C4, or would you do the C4 and the C1 inhibitors?
I would do it all. You really want to kind of help establish the diagnosis, the type. Sometimes we'll also get a C1Q to kind of help also further clarify. We don't perhaps think a lot about malignancy in this age group or acquired angioedema, but that if we wanted to for completeness sake, that could also be something that we could obtain. But yeah, in this situation, I would do the C4 and the C1 inhibitor studies.
And oftentimes that genetic test wouldn't be immediately available either, right? So the C4, the C1 inhibitor level and function would. And I know you got lab results on your patients, so I'm not going to make anyone wait any longer, but I want to see them too. So there we go.
So here we go. Well, if we're looking at the C4, it is 2 milligrams per deciliter, so that is of course is low. The C1 inhibitor is low, and therefore C1 inhibitor level is low, and therefore the function is also low. And as I was kind of saying already, we often also get the C1Q, which was normal, which this all tracks with the diagnosis of type 1 hereditary angioedema. If we just kind of want to, for didactic sake, if the C1 level was normal and the C inhibitor function was low, in which case that would be type 2.
And of course, if they were both normal, it would be more of the normal. And then you may go down the different road, right?
Correct. Yes. And if C1Q was low, then like I was kind of hinting at earlier, we would go down the road for the concerning acquired angioedema pathway.
And certainly in older patients, the C1Q is more often ordered, right? For those things that you mentioned. Okay.
All right, so our next audience polling question. The patient is diagnosed with HAE type 1. What type of on-demand treatment would you prescribe for this patient? Would it be A, C1 inhibitor, B, icatibant, C, ecallantide, or D, sebetralstat? We'll give the audience a few moments to answer.
And she's 12, this patient, correct? She's a
Well,
12.
it is important to clarify that.
Yeah.
Yes, indeed. Okay. So, all right. Well, we kind of have a mixed bag here, and again, there are really no, I think, wrong answers on the whole for this question. The approach to selecting an on-demand therapy, I think, as Dr. O'Connor nicely outlined, needs to be individualized with consideration for the patient and also the caregiver. What are their skills and where is their confidence? So we had 50% of the audience answer C1 inhibitor. We had 20% answer icatibant. We had 10% answer ecallantide, and then we had 20% answer sebetralstat. So let's go down to each of these. So the C1 inhibitor is age appropriate. There are some, aspects to this where basically you have to start an IV. So that sometimes can be recognized as a treatment burden for if it's a 12-year-old, she probably is not going to, be wild about starting her own IV. Some are, but not, maybe not many. In which case we go to the caregiver and kind of gauge their interest. There are a lot of good training options out there to get accustomed to this and learn this. If we move on to option B, icatibant, unfortunately here in the US, this is only approved for 18 and up. So technically not really an option for this patient, but it is approved for younger age groups in Europe. So not entirely wrong if maybe we were, overseas. Option C, ecallantide. Again, that's age appropriate, but it has some additional layers of maybe treatment burden where this IV in a healthcare provider. So either as an outpatient option or an emergency room. And then option D, sebetralstat, which Dr. Connor kind of went over earlier, how this is our new and first oral agent for acute therapy. So obviously that's going to have perhaps some benefit over some of the others as far as treatment burden and the speed at which one can deliver this medicine. As we know with HAE and bradykinin-mediated angioedema, kind of the longer the delay, the longer there's a swell, and it's kind of hard to turn that around entirely. But this is kind of the way I would approach it. Dr. O'Connor, do you have any?
Yeah, and I agree.
Here?
I agree with you totally. And I think that having the IV option is something to definitely discuss. I have had patients in this age group who have chosen that, feeling that they wanted to have the control, that they felt that it could be more control. But then there are others who absolutely are needle phobic and would never want to go through that. So then an oral option may be more beneficial. With the oral option being newer on the market, that's a consideration for that shared decision-making discussion. And when I said review the data, and when I say that when I'm doing live lectures, sometimes people look at me and they say, do you really go over the data with patients? I don't go over it in the detail that we would with healthcare providers, but I think them understanding, exactly the efficacy and the safety, I think it's very important. Again, some of these have been on the market for much longer than others, but the FDA approves them based on the studies. And so sometimes I absolutely will go over that. And in the case of this patient, I think the family history, if you, I don't know yet, because I don't know if you've diagnosed the other family members, but certainly sometimes I've seen when there's multiple family members with HAE, sometimes they would like to choose the same therapy. They think, oh, if it worked in my sister, it may work in me, or they're more comfortable with that option. So just some sort of practical consideration. So I'll move on to what you all did for your patient.
Yeah, I was just going to say that's an excellent point. A lot of patients do want to know about a track record of a medicine,
Right.
and there's sometimes trepidation about things that are new, but there are also some family allegiances and comfort with certain therapies, and they're familiar with it. So that definitely plays a factor. So thank you.
Yeah, absolutely.
So moving on with her patient. So since her first visit, she reports an unprovoked hand swelling event that occurred, took 2 days to resolve. Her family was undecided about starting prophylaxis, but they requested recombinant C1 inhibitor for acute therapy. Um, we also addressed a HAE action plan letter with treatment instructions for providers and ED visits, and also, of course, for her family. We really went over resources and that this is, several aspects of HAE where this is a lifelong disease, and it's important to take every swell seriously from here on out. Of course, her mom voiced concern about participation in contact sports like soccer and volleyball. Um, and so that was a discussion. I should also point out here this she had made the decision to do the recombinant C1 inhibitor. She at the time that she had presented before sebetralstat was FDA approved. But anyhow, we moving on. We later initiated prophylaxis with sebetralstat about a week later when she called back after they had reviewed the options on their own. So subsequent follow-up and treatment for her. About 6 weeks later, we had a visit. She fortunately had no more swelling attacks. She had not yet needed her acute therapy. She was playing sports again with increased confidence, probably for her and also, of course, her mother and her caregivers. 4 months down the road, she still remained attack-free on berotralstat. She had not yet needed her acute therapy. And at that point, since it had been several months later, we discussed the latest approved therapy in sebetralstat as a potential option down the road for her as well.
And I think this is right here is where I would say, even though she's doing well and attack free, which is what we hope and we want for our patients, that on-demand option still needs to be available, which you clearly have done appropriately. But we have patients sometimes who will say, well, I haven't had any problems. Do I really still need my on-demand? And that's where that follow-up appointment is so important, and where that written action plan and just reviewing things again. Because just because they've had no trouble doesn't mean that they can't. That unpredictability, we don't ever know for sure. And I tell patients it may be a little bit burdensome to have an on-demand option available, but it's certainly less burdensome than needing it and not having it, right? And so that's great. And I notice here 6 weeks and then 4 months, that's about the same amount where I would follow up with a patient that's doing well. And certainly if they're not doing well and they call in, they can be seen sooner. But I think that's a very nice timeline, and patients appreciate it as well.
Yeah, agreed. Especially in that first year, that first kind of understanding of the diagnosis. I think it's important to follow up with them and have an open line of communication with them whenever they need it.
And did you discuss with the family genetic testing for the mom and the I guess there was the distant relative as well?
Yeah. Yes. So we did, without going into too much detail, there wasn't a lot of communication with her kind of extended family, if you will, but it was definitely something we discussed with mom.
Yeah. And the burden of I mean, I noticed you said she lives with her mom, so just the two of them in the home, the HAE burden, we talked about it going beyond the acute attacks and the in-between attacks. And that, of course, is on the patient, but it's also on the caregiver. And being a single mom of a patient with this rare disease, I'm sure you've had to do a lot of discussions with mom as well, to
Yeah,
help her navigate this, right?
agreed. I mean it's as her parent, probably she would probably have a lot of additional levels of anxiety where she's trying to do something, go away or be apart from her daughter at times. Then who's going to be there to help with her and start her IV or get her to the emergency room and explain her situation? I mean, she's 12, so she may not be able to really vocalize a lot of these concerns. And then also, if maybe, she's staying with a family member, they may not be familiar even with her staying on her prophylaxis. I mean, having a child routinely take their medicine every day doesn't always happen. So these are some aspects that I'm glad you point out with a kind of a single parent household.
Right. Yes. And, this is a time, of course, where you would involve her, but being 12, it's difficult. It's a difficult age. They don't always want to do what they're told. They don't always want to follow. And the burden of just having the disease at all, the embarrassment that can go along with this with our patients. And that preteen and adolescent time is particularly stressful, right? And so you worry about friends and their opinions and that kind of thing. So I know that this is patient seems like a slam dunk with the diagnosis, but there's a lot more to it. There's layers of treating HAE patients that really cannot be minimized. And so any further points before we get to our key takeaways and take some questions? Okay.
Not for mine, no.
All right. So just as a reminder, the things we talked about tonight. So even with prophylactic therapy, like Dr. West's patient, HAE attacks remain a significant burden for patients and really highlights that need for prompt recognition and prompt treatment and having that treatment available. Safe and effective on-demand therapies include C1 inhibitor replacement, icatibant, and ecallantide, and of course our most recent. Acute treatment options are expanding. Oral agents, as we've mentioned, emerging bradykinin B2 receptor antagonists, deucrictibant, again, just demonstrating good efficacy and safety. And again, that newly FDA-approved sebetralstat, the oral plasma kallikrein inhibitor. And then just reminding everyone the rapid treatment of all acute attacks is recommended with attention to route of administration, onset of action, and tolerability, and personalizing that management through shared decision-making, patient education, and re-education on follow-up visits can improve health outcomes, help normalize the quality of life for patients with HAE. It's a long journey for these folks. And so these are some key points that can help us all manage these patients once they're properly diagnosed. So now I will certainly take any questions from the audience. I know there's a question box and a chat box, Dr. West. I'm going to see if you can navigate that for
I've got
questions.
Great. I've got it open here. So our first question, I think it's a good one. How do you navigate treatment for patients that frequently travel?
I think that's
so. If I'm just going to jump in here, yeah, it's a great question, and this is definitely a consideration, as we kind of highlighted on earlier. Often a stressful point. And that's also why we really try to emphasize having a good written plan that everybody's aware of. We double check our medicines, our supplies. We know where we're going, and we might even look up where there's some emergency rooms there. HE is getting better, and management is getting better known, especially if you're going to a major city. But if you're not, then having your letter and your plan established is very important.
And I know that you have your, on-call healthcare providers from your clinic, and I do as well. And as burdensome as it can seem to have a call from the emergency room or the urgent care, I would rather have that call and have my patient properly managed with that written treatment plan than have them have unanswered questions and maybe go through some of those unnecessary diagnostic tests or unnecessary treatments that we know aren't going to work. And that's that partnership that we as HAE experts have with our patients and their caregivers that can really optimize them so they can travel frequently if that's something that they choose to do. I travel frequently, and it's hard to remember everything that you have to pack. So having a list is very helpful for me. So having that written treatment plan can be very helpful. And I like your idea of the calling ahead or knowing ahead, like there's an emergency room this far away, or there's an urgent care that's open 24 hours, and this is the medical director there or something. But I agree also that it's gotten easier to navigate over time. Again, having clear, concise instructions. So that's a great question.
Excellent. Thanks. So we got another good one here, and I think it's important to touch on. So how do treatment guidelines for HE change during pregnancy, and what are the preferred options?
Okay, hang on one second. I think I have a slide for that, Dr. West, that might be helpful.
Awesome.
Hang on one second. Here we go. There we go. Yeah.
Oh, excellent. So yeah, I'll just jump in here. So in pregnancy, we do have preferred options and some options with kind of limited data, but essentially the C1 inhibitor products are preferred for both on-demand and short-term prophylaxis. And this is something that we, always have to discuss with our women of childbearing age that they may be on another acute or even prophylactic therapy, but if they're thinking about it, it's actually a consideration early on, and whether or not we may need to go use a C1 inhibitor product. Also, for further clarification, recombinant C1 inhibitor is also acceptable. There's limited data on it, obviously, for ethical reasons, but that would also be an option. Icatibant and Calantide are generally not recommended. And then lanadelumab and berotralstat, there's really no data on this as well. So really, it comes down to C1 inhibitor product.
Right. And obviously in your 12-year-old patient, we would hopefully not be talking about pregnancy yet, but it would be a consideration down the road. And of course, oral contraceptives would be something to discuss as well. Unfortunately, in this day and age, it's starting younger and younger as well. So then you might be having that conversation sooner than you think, right? So thank you for that. And that was a nice summary of the pregnancy options. Any other questions that we're seeing, Dr. West?
So I'm just kind of reading through here. We have a question from the audience. And I think it kind of pertains to the slide presentation. On the family history, what do you mean by swelling, sting? Is there any one do not swell when they got sting? So yeah, and that was kind of I think maybe the point is that there was some swelling, but it was a vague history of related to stings. And then her other family member assumed it was a food allergy. And as we know, as allergists, that's not always really the case if it's isolated swelling. All right. So I think that's a good question, and want to clarify that, yes, most of us sting when we get stung, but it was just more of a notable family history aspect to perhaps further give historical clues that this is likely a bradykinin mediated swell or an HAE or hereditary swell.
Yeah, and certainly with insect stings, swelling out of proportion to the sting would make us think about either histaminergic or bradykinin-mediated angioedema, because we could go down the road of mast cell disorders, right, and check tryptases. But with this particular patient's history, I think HAE was obviously the right path. But also, there's still some stoicism in the older populations about diseases and symptoms, right? So we even hear that with cancer. Like, I think my great-grandmother might have had cancer, but they didn't talk about it. And so even that swelling that was described from the insect or even the food may have been allergic, but may not have been, depending on the detail, which you didn't have, right? So in fairness, the swelling was pretty good that you got that history at all.
Thanks. And those kind of make up the questions that I see. So.
Wonderful. Well, I will just tell you that was an excellent case, and very very great presentation on that. And thank you for your additional points. I think it's again important that HAE is properly diagnosed early, and that every acute exacerbation is treated regardless of severity and location. And it was a true honor to present with you today, Dr. West. I really appreciate this. And I hope we were able to shed some insight into the management of HAE and on-demand treatments. So thank you very much.
Thank you, Dr. O'Connor, and the honors all on this side of the table. So thank you. You did a fantastic presentation and really, I think, help educate us, and your depth of knowledge in this area is awesome. So thank you.
Thank you very much. And thank you to Integrity, and thank you to Pharming Healthcare. Thank you. Good night, everyone.